Okay, everyone, thank you so much. Welcome to our monthly webinar, Season Speaks, a virtual series. Thank you for joining us today for this month's topic, Let's Talk COVID-19 Vaccinations. I'm Amanda White, the Senior Director of Marketing and Communications for Seasons, and I'll be your host today. For background, Seasons is a Canadian retirement home company that was established in 2009. We operate 21 retirement communities in Ontario and Alberta, with more in progress. We have proudly created a culture that is dedicated to providing residents with superior customer service, because we want our residents to be proud to call us home and to know they're surrounded by people who genuinely care. Today, I'm joined by Dr. Tim O'Callaghan, who will be leading our webinar topic on Let's Talk COVID-19 Vaccinations. Dr. O'Callaghan is a family doctor and lead physician of the Amherstburg Family Health Team. He's the medical director for 2 long-term care residences and 3 retirement homes. He represents primary care at a regional, provincial, and national level. Today, we'll cover the history and facts associated with viruses and vaccines, and we'll provide clarity on what the COVID-19 vaccines mean for today's seniors and what life looks like after being vaccinated. So with that, I'm going to turn it over to Dr. O'Callaghan, who's going to walk you through today's agenda.
Amanda, thanks very much. And thanks to Seasons for bringing me here. This is a great opportunity. So I'm a family doctor, and I'm going to give you a family doctor perspective on COVID-19 vaccines. I'm not a virologist or microbiologist or public health expert, but I am having these discussions with my patients every single day in regard to the various vaccines that are available. So that's what I hope to bring to you today, a better understanding of the present landscape of vaccines. I'm going to start today's talk just reminding you about the seriousness of this viral infection, the pandemic that we're under. Talk a bit about transmission and protection. These are things that you probably already understand a great deal about, but I'll review those for you. To understand how vaccines work and the COVID-19 vaccine works, it's really important for us first to understand how viruses work. So I'm going to walk you through that with some cartoons that Seasons has very, very nicely prepared for me. And once we understand how viruses work, we're going to have just a basic talk around how vaccines work and how we could have designed COVID-19 vaccines and how we did design COVID-19 vaccines. And then finally, I'll land on the meat of the topic, which is discussing the COVID-19 vaccines that are available, a little bit of talk around effectiveness and safety, and I'm going to end with some words about variants. So a brief history of the pandemic in under 3 minutes. So just over a year ago, the World Health Organization declared a COVID-19 pandemic worldwide. And as you recall, that's a pandemic that started as an epidemic of respiratory disease in Wuhan, China. And initially, they didn't know what they were dealing with, but rapidly they identified the causative agent, and it was what they called a novel coronavirus. Novel because it was a brand new virus. It's something that our immune systems had not been exposed to before, and that's what makes it so dangerous. You'll recall that initially we heard about respiratory symptoms with this virus, and we've come to learn a lot about it since then. Some patients present with respiratory symptoms, so it can be things like nasal and sinus congestion, a sore throat, problems with cough, problems with shortness of breath, fever, and lethargy are really important features of this. And then there are other less common effects, such as a change in taste and smell, nausea, vomiting, abdominal cramps, etc. In kids, they often present with rashes. And so there's a constellation of features. And the other important thing to realize is that for some people, they have absolutely no symptoms whatsoever. So they can be asymptomatic, yet continue to be infectious. And that's what is one of the main reasons that this is spread so incredibly quickly. Some of the important points to talk about, and I guess we always hear about the death rate associated with COVID-19, and that is definitely important. For younger patients, that's unlikely, but not impossible. as we have patients that are older or those with more and more medical comorbidities, the mortality rate goes up. And in some unfortunate outbreak situations in long-term care, death rates of 20, 30, even 50% have been seen. And so that's definitely something that you're hearing a lot of in the media. I think what we sometimes focus a little less intensely on are the long-term effects. And so this is emerging science around what are the long-term effects of COVID-19 on the body? And also, what are the impacts of this pandemic on our health system generally? So, a lot of necessary procedures have been delayed as a result of lack of access to healthcare. So that's a major way that this virus is having an impact on us. And the pandemic pressures are definitely having an impact on mental health as well. So those are some key things just to remember. This is a serious viral infection, and vaccines are one of the ways that we're going to use to mitigate. So I'm going to talk just briefly about transmission. So we've heard about contact transmission of this virus, and this involves respiratory droplets. And so direct contact with droplets works like this. When someone breathes, coughs, or sneezes, small droplets leave the person's upper airway. And if coronavirus is in those droplets, they've got the ability to make it to the person that's nearby. This is direct transmission. If those droplets should touch the patient's mouth, nose, or eyes, this is a site of entry for the virus into the body. The other indirect way that transmission can occur is if this person that's infectious should cough into their hand and then reach out and touch a surface such as, for example, the doorknob, and then walk away. And the next person touches that same doorknob and then touches their face, they've got the potential to infect themselves that way too. Next slide. So some of the ways that we can help protect ourselves are shown here. So using a mask is protective in that if you have the virus, you're less likely to transmit it. If you don't have the virus, it's going to protect your mucous membranes from being infected. You'll see that this person has a mask on. In healthcare, we also use means to protect our eyes. Frequently sanitizing surfaces is an important feature. Hand washing and using hand sanitizer is an important protective measure as well. You'll see here that if someone steps back to that recommended 2 meters and then this person coughs, those respiratory droplets do what droplets do. They drop down to the floor where they're not going to be harmful. This person has also protected themselves by wearing a mask. Even better would be if the person that was infected here had worn a mask as well. That would prevent virus from transmitting to the other person. So that was just sort of a review to let you remind you of the things that we should continue to do as we move forward through this pandemic. I'm going to speak a little bit about viruses, and I wish that a simple microscope like this was good enough to identify viruses, but they're very, very small. So we need special technology like an electron microscope to actually be able to see them. This is a scanning electron micrograph of the coronavirus. You'll see the configuration of the virus, and I think you've seen these pictures in the past, is there's a central core, and then there's all of these little spikes on the surface that are called spike proteins. And so that's an important feature of the virus that we'll come back to later when we're talking about vaccines. Here's how a virus works. So referring to figure 1, the left side of the screen, we've made some little cartoons here, and that's meant to represent the coronavirus. So the spikes on the side are the spike proteins. The circle is the core of the virus. And then you'll see a little yellow squiggly line there. That is meant to represent the RNA, which is the genetic material. It's really the blueprint for the virus to make more copies of itself. Moving to the right side of the screen, this virus attacks the human cell when it comes in through the mucous membranes, as we described previously. The next thing that virus does in figure 3 here is it attaches onto a receptor on the surface of the cell. And those of you who are listening carefully are going to say, why does a human cell have a receptor for a virus? And it's not a receptor for the virus, it's a receptor for some other biologic process that's important for the cell. But the virus uses this, it tricks the cell into thinking it's something else. It attaches onto this receptor, and that basically is the key that unlocks the door and lets the virus be taken into the cell, as you see in figure 4. What the virus then does is it breaks itself open and it releases its genetic material, the RNA, into the cell to try to make more copies of itself. Figure 5 shows what happens. And so human cells are really, really good at doing a few things, and many things, but one of the things that human cells are capable of doing is replicating RNA. So there's machinery within the cell that replicates RNA. The virus takes over that machinery and makes a whole bunch of copies of RNA. And it also uses this genetic blueprint to make proteins. And so proteins are the things that make up the virus. There's more than just the spike protein in the virus. And so that blueprint encodes for all of the proteins that make up the virus. Essentially what the virus has done is taken over the cell as its own personal factory to make more and more and more copies of itself. As you see on the right side of the screen in figure 6, that process keeps going and going and going until the cell is completely packed solid with virus, and then it breaks open. That damages the cell, so that causes death of the cell, and then it releases virus into the system. And if this is in the airway, that's a virus that can go further down the airway and involve other parts of the respiratory system like the lung, or it can be coughed out or breathed out and transmitted to another person. Now, the human cell, to say clearly, is really good at this production process. And usually the copies that it makes of the virus are perfect copies, perfect clones of the original virus. But occasionally it makes a mistake when it's making copies of the RNA. If the mistake that it made, and that's a mutation, leads to a virus that doesn't work, then nothing happens. The virus is not infective and that virus just dies. But if the mistake that it makes leads to a virus that is effective, then that virus can go on and continue to infect. And the mistake may be seen as a slight change in the spike protein. So that's how a mutation occurs to cause a new strain or variant of the virus. So what happens when a new virus like this that we have no previous immunity to comes into the system? Well, the immune cells are there. The virus approaches the immune cell, but there's no recognition on the part of the immune cell to the virus. So I'm showing here these receptors on the surface of the immune cell don't match up with what's on the surface of the virus, so nothing happens. And so initially what occurs is the virus replicates and it goes up, 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 and nothing's happening with the immune system to start with. And so we, with other infections where we've got previous immunity, as the virus starts to go, the immune system quickly starts to go and overtake, but because this is a novel infection, that doesn't initially happen. In the next figure, you'll see that in fact what happens eventually is the immune system says, hey, wait a second, this is something new. This is an infection going on and I need to respond to it. So it actually creates on the surface of the cell receptors that match in, that lock in with the shape of the proteins. So this is the so-called lock and key mechanism for immune function. There's a specific receptor for that protein on the immune cell. When that happens, the immune system is stimulated and two things happen. the immune cells increase in number, and they also make antibodies, which are the same shape to attack the virus. And that's how the immune system eventually builds up and takes over the virus. In that race with the virus, if the virus multiplies more quickly than the immune system can respond, we get to a point where the virus is overwhelming and can cause death to the person. Usually what happens is as the immune system catches up and then beats the infection, that the infection is therefore cleared out of the body. So I'm going to take you through just a basic understanding of generally how vaccines work. So on the left side of the screen, really what we're trying to do is we're trying to induce the immune system without causing an infection in the person, to what I just talked about with viruses. We want to take that immune cell, which is not ready and doesn't have receptors for the virus, and turn that into an immune cell with receptors for the virus that is then ready to go. This is called immunologic memory. And so we want to create memory so that the immune system is totally primed and ready, so that later, if the virus comes into the system, the immune system instantly says, wait a second, we know this, and we wipe it out. Hopefully to the point where we don't even create disease. We wipe the virus out so that it doesn't actually cause infection, as a best case scenario, but as a second best case scenario, that at least the infection is a mild infection and isn't fatal to the person. So how can we do this? You know, what are the things that are in that needle that we get that can cause this to happen? So you can imagine that one way of doing it would be to say, isolate COVID-19 virus, somehow inactivate the virus, and inject that into the body. And it's possible, and that is done with other types of vaccines. That, however, is not what we did with COVID-19 vaccine. Another possibility is that we somehow in a lab engineer the protein. So we build a whole lot of these little spike proteins, not the virus itself, but just the protein from the surface. If we could make those, put those in a needle and inject that, that's the way that numerous other vaccines work. We thought about that. That would also induce an immune response, but that also is not what we did with COVID-19 vaccine. What we did was isolate a little piece of the material, the blueprint from inside the virus. This work actually happened well before we even really knew there was a big problem going on. We knew things were going on in Wuhan, and in early January 2020, they had already sequenced the viral genetic material, and so they knew exactly what it was, and they were able to find the little piece of that that's responsible for the spike protein. They clip that out, and then the idea is, well, what could we do with that? So if we were to inject that in a way that it's going to be taken into cells, the cells, just like I said earlier, are really good at taking that viral blueprint and making copies of protein. And so that's what the cell does. So the cell itself, again, becomes a factory for the protein, not the whole virus. So you're not going to get sick from it, but you're going to have a whole bunch of this spike protein. That then can induce the immune reaction that we want to see. And that is exactly the way that the RNA vaccines that are out there, which are the Pfizer and Moderna vaccine, work. So they are RNA vaccines, and that's the technology behind it, or that's the idea behind it. The other methodology that we could use is to take that same little clip, and rather than inject the clip directly, that we would put it in an inactivated virus, in this case, something called an adenovirus, and that we would inject that. That virus then goes into the cell, gets taken into the cell, and creates copies of protein within the cell. And once again, we're to that same common pathway where we've got lots of spike protein. The immune system sees that and says, hey, wait a second, this isn't supposed to be here. And we get that immune response so that we're ready for next time. This is the technology that is used in the 2 adenovirus vaccines that are available, which are the AstraZeneca vaccine and the Johnson & Johnson vaccine. So that brings me to talk a little bit more specifically about the COVID-19 vaccines. So again, the Pfizer and Moderna vaccines are RNA vaccines. They're very similar in terms of side effect profile and effectiveness. They are both 2-dose vaccines. The AstraZeneca was one of the adenovirus vaccines. It's just recently become very available. And it is also a 2-dose vaccine. Johnson & Johnson is also an adenovirus vaccine, and it's a single dose. So those are the basic differences between the vaccines. I'd like to talk a little bit about effectiveness, and this can be a little bit confusing. And so how do we measure effectiveness? I guess, as I said earlier, really what we're concerned about is we want the immune system to rally up, and we would like it to rally up so that in advance of infection, we're ready to go. And if the virus tries to come into the body, we stop it there and don't create any infection whatsoever. That's what the numbers that you're hearing stated in the media in regard to the effectiveness of the vaccines. And so both of the RNA vaccines are 94, 95% effective at that outcome. The adenovirus vaccines are more in the line of 65 to 75% effective, depending on the vaccine, at that outcome. Again, at symptomatic COVID infection. If you can picture what's going on, really what we're saying is if you compare the placebo group in these studies to the vaccine group, they were able, so if there were 100 patients in the placebo group that developed symptoms of infection, in the RNA vaccine trials, only 5 people developed symptoms of infection. In the adenovirus, 25 or 35 people would develop symptoms of infection. But the important thing to realize is that irrespective of which vaccine, the really important outcome, which is serious COVID, is almost 100, and death from COVID is nearly 100% reduced. And that's really the most important. So as I'm talking with patients about this, I say, you know, if I take this from a virus that you come into contact with that could kill you and turn it into a situation where you might get a runny nose and a sore throat, I'm okay with that. What I really don't want you to do is have a bad outcome from COVID, have to be hospitalized, or worse yet, die from COVID. So that's a bit of point about the effectiveness of the vaccines. Side effects occur with all of the COVID-19 vaccines, and they're fairly frequent. To be honest with you, they're more frequent than what I would normally see with an influenza vaccine. We see more than 50% of people developing some sort of side effects. Often side effects can include things like tiredness, headache. There can be fever and chills, nausea, and commonly some pain and redness at the injection site. Usually these symptoms are very short-lived. Personally, I've had both of my vaccinations, and I had no symptoms other than minor sore arm after the first dose. And I did feel chilled and tired the day after my second dose, and that was it. So that's the sort of thing that we can experience. What about severe reactions? And so that's the term that you're hearing in the media, anaphylaxis. So anaphylaxis is generally an immediate reaction to a vaccine, but it can be to really any medical product. Anaphylaxis happens, at a frequency of about 1 in 70,000 with penicillin, for example. So it's not something new. Anaphylaxis causes swelling in the lips, tongue, and throat, and can almost instantly start to impair breathing. It can have an impact on your blood pressure, causing it to bottom out, and it can have an impact on many other body systems as well. It is a serious but treatable side effect of vaccines, and it occurs very rarely. I tried to make a graph comparing what anaphylaxis looks like per million people vaccinated with what the death rate from COVID-19 looks like per million people. And you can't even see that the anaphylaxis occurs in 2 to 6 persons per million vaccinations. And it's important, I think, to put that in the context of what the chance would be of dying of COVID generally is about 16,000 people would be expected to die per million people if they remained unvaccinated and got infected. So anaphylaxis is definitely important. The thing to realize about it is anyone that's doing vaccination stands ready with epinephrine to treat anaphylaxis if it occurs, and it is generally a serious but treatable side effect of vaccine. Just a word on variants. And so I did earlier in the talk speak about how variants happen. It's just that when there's so many virus particles and so many people worldwide being made, occasionally errors happen. And when an error happens that results in a more infectious virus, then that virus emerges as a variant. And so the shape of the protein is not quite exactly the same in a variant as it is in the original virus. And so the concern has been maybe the vaccines that we've developed for the original virus aren't going to work as effectively. And initial information really says this, that although some of the variants don't respond quite as well to vaccination, there is still great protection even for variants. For many of them, there's very similar protection to the original virus. So the people are wondering, should we wait until a new vaccine is developed for variants? The answer is no. COVID-19, the original virus, is still out there, and that is the important thing to be immunized against, and getting that will provide protection from variants as well. So in summary, I hope you've learned something about viruses and vaccines today. I hope I've improved your confidence in understanding vaccination and COVID-19 vaccines specifically, and I'm ready to take your questions.
Thanks, Dr. O'Callaghan. I got excited for that Q&A period, so I jumped in quick. Thank you for your insightful presentation. So as Dr. O'Callaghan said, this is now our live Q&A period. If you haven't done so already, please submit your questions by using the Q&A button on the bottom of your menu bar. Please feel free to continue submitting the questions even as we're going through it. We'll do our best to answer any questions you have live. So we do have some great questions here, and we can get started. Okay, so the first one is one that we get asked quite a bit. If I'm vaccinated, do I need to keep wearing a mask?
Yeah, so the answer is really these are public health decisions. And so we're going to look to public health for their guidance on this. In Canada, there's no recommendation yet in terms of any relaxing of those basic measures to decrease the spread of COVID-19. But as we move forward with this, and we can look south of the border to what the CDC has recommended, they recommend, for example, now, and again, this is in the States, not in Canada, but if you have a vaccinated person that's in contact with another vaccinated person, that they, at that point, can stop wearing masks and stop social distancing. But there still are restrictions in terms of contact with people that are unvaccinated. So for the time being, let's stick with what public health is saying, but we can certainly see an end coming as more and more people are vaccinated.
That's great, thank you. And we know that for retirement homes specifically, the directives remain the same for us. So, and we're doing our best to protect our most vulnerable. So we're still wearing masks. Okay, I have a question here. Dr. O'Callaghan, do we have a choice of the type of vaccine that we receive?
Yeah, so there are 3 and soon to be 4 vaccines available. And the answer is you probably are going to be offered a single vaccine. And my recommendation is definitely to move forward as quickly as you can with getting vaccinated, rather than thinking you're going to do yourself better by waiting for a different choice. I didn't get into a lot in the presentation around, why is there a lower number associated with the effectiveness of some vaccines compared to others? And it may not really be the vaccine. It may be where the vaccine was studied and in what population it was studied. So when we look at different numbers from, when we look at the same vaccine in different parts of the world, it looks different in different parts of the world. So vaccines that were studied, for example, a lot in Brazil, where they have the Brazilian variant that doesn't quite respond to vaccination as much. If you did a lot of your study in Brazil, your numbers aren't going to look as good. If you did your study in the US, your numbers might have looked better. And so that's the case, for example, with the AstraZeneca vaccine. My advice is to get the vaccine that's offered. You're probably going to have one particular vaccine that's being offered where you're getting your vaccine. So go ahead with it and don't delay.
That's good advice. Thank you. We have a question here actually about allergies. I know you spoke to this, but this question is specific. Are any of the vaccines safe if you are allergic to specifically propylene glycol and formaldehyde?
That is something that I would have to look into. So yeah, so each of the vaccines carries with them very specific recommendations in regard to allergies. That is something that you would need to look into. My advice would be to speak with your primary care provider. They'd be able to look that information up for you.
Okay, that's great. We have a question here. How long is the virus active on surfaces?
It depends on the surface, but and honestly, at the beginning of this pandemic, we really played the possibility of indirect contact up. It definitely occurs, but it occurs way less frequently than we initially thought. So mostly how you get this is by coming in contact directly with someone. And so it's much less likely to come into indirect contact with the virus. So I'm less concerned now about surfaces than I was a year ago. I'm still concerned. We still do all the protocols, and I'm sure all of the season's homes are doing all of the protocols in terms of cleaning surfaces on a regular basis, but I'm less concerned about that. It depends on the surface. So some surfaces can keep virus alive a little bit longer. But in general, a day later, most surfaces there's no potential for getting infection from that surface.
Okay, great, thank you. Next question: what happens if you only have one dose of a 2-dose vaccine? For example, what is the requirement for the second dose?
Yeah, so in general, we're going to recommend for the 2-dose vaccines that everyone get the 2 doses. There has been some change, though, as we've gone through this in regard to the timing of the second dose. And so the original thoughts were for the Pfizer vaccine, that was 3 weeks, and Moderna 4 weeks. That has now been pushed out to 4 months. And so people sort of say, well, why did that happen? And the answer is, you get almost all of the protection with a single dose as you do with 2. And that protection has now been shown to last for at least 4 months. And if you could, get 90% protection in 2 people, wouldn't that be better than getting 95% protection in 1 person? So that's really where this came from. If we had unlimited vaccine, unlimited vaccination available, we would be doing them per protocol. But the interesting thing that's come out of this, the concern has been, well, does delaying it affect the long-term outcome? And it really looks like it's a positive thing, actually, that delaying the second dose increases your long-term antibody response. So it's actually not a bad thing for the person individually as well.
Okay, great. Another question. Sorry, is the vaccine altered for people with underlying medical conditions?
Nope, the answer is people with a variety of underlying medical conditions have been vaccinated. In fact, that's really the focus right now, is specifically tailoring our approach to those at higher risk, which are the people that are older and those with serious underlying conditions. And so it's exactly the same protocol that's in place in regard to the vaccine that's given, the dose that's given, et cetera.
Thank you. Are the vaccines good for a lifetime, or will they be required annually?
That's a really good question, and one that we don't have an answer for. Unfortunately, of course, these vaccine trials were all completed just months ago. And so that's the data that we've got presently. And so we don't have an answer to, is the protection that we saw at the end of 6 months, this is going to be the same at the end of 18 months, 24 months. We really don't know yet. So that's a question just in regard to the durability of effect from the vaccine itself for the original virus. The other question is, if we get new variants, if they're significantly enough different from the original virus, what we might need to do is engineer a slightly different vaccine in future years to deal with variants if they're becoming more prevalent. That's exactly the approach that we take with influenza vaccination every year. And so I anticipate that that might be what we need to do going forward, but really we don't have enough information on this to be able to forecast.
Okay, that's great. Actually, here's a question that I can answer. Do new residents get vaccinated when they move into seasons? At this time, different regions have different approaches for new move-ins. We can confirm that public health is working with our teams and looking at creative ways for new move-ins to participate if they've missed our original vaccination clinic. And now we're seeing that residents can actually be vaccinated as members of the greater community if they meet those age requirements. So more and more residents are being able to get vaccinated, which is really great news. With that, actually, that's going to conclude our Q&A period as we're getting close to the end of our presentation here. So with that, I'm going to go ahead and conclude today's session. Thank you for joining us for this month's Season Speaks, a virtual series, and a really big thank you to Dr. O'Callaghan for leading today's presentation and providing this very important and valuable information to all of us today.
Thank you so much.
Thanks. If you're interested in getting in touch with us or for more information, to book a tour, please visit our website at seasonsretirement.com. You can also find us on Facebook, Twitter, Instagram, and LinkedIn. Be sure to click like or follow to get the latest updates for our next Season Speaks webinar in April, and we hope to connect with you all soon. Thanks again. Bye, everyone.